Would like to present a clinical case of 55-year-old female patient from Kirkuk. She is known to have diabetes mellitus. She presented with acute dyspnea that started in the morning. On examination, she had tachypnea, acidotic breathing, vomiting, and sign of dehydration. Vital signs showed Glasgow Coma scale of 15/15, blood pressure 11/60, oxygen saturation 93%, and her temperature 36.6. Her chest was clear, she was agitated but had no cyanosis, and her abdomen was soft. The combination of diabetes, acidotic breathing, dehydration, vomiting, and normal chest exam strongly pointed toward DKA as initial diagnosis. Initial investigation to confirm diagnosis included complete blood picture, random blood sugar and urine analysis, renal function test and electrolyte panel, arterial blood gases. Her complete blood picture reveal significant leukocytosis, as we see with normal hemoglobin and reactionary thrombocytosis. It's important to note that most patients with DKA present with leukocytosis even in the absence of infection. This is due to stress-induced demargination of the white blood cell. Therefore, leukocytosis alone shouldn't be interpreted as a sign of infection. Her random blood sugar was over 400 and urine analysis revealed ketonuria 3+. Her electrolyte panel initially showed mild hyperkalemia. Her potassium was 5.7. Patients with DKA often have mild to moderate hyperkalemia at presentation, despite having a total body potassium deficit. This is due to the shift of the potassium from the intracellular to extracellular space. However, once insulin therapy begins, potassium shifts back into the cell, which can cause a rapid drop in the serum potassium level. This was exactly what happened next day. Her potassium dropped to 2.4. Arterial blood gases showed indicating severe acidemia, PCO2 12 mm mercury, respiratory compensation, PO2 105 due to hyperventilation, lactic acidosis 4.4 suggesting sepsis and shock, high anion gap consistent with severe diabetic ketoacidosis. So she was started on IV fluid, insulin infusion, sodium bicarbonate, antibiotic according to the local guideline. Later on, her dyspnea worsened with epigastric pain, and she was transferred to the RCU and sent for pancreatic function test. Amylase was 1790, more than 10 times the normal limit. Lipase was 92, about twice the upper limit. However, elevated pancreatic enzymes are common in DKA and often reflect metabolic stress rather than true pancreatitis. Clinical correlation and imaging are essential to avoid misdiagnosis and unnecessary intervention. An abdominal ultrasound revealed 2 small gallstones with normal common bile duct and no evidence of pancreatic inflammation. So we continued on DKA therapy with monitoring of pancreatic function test. After 3 to 4 days, the ABG improved, pH showing partial correction of acidosis, lactate normalized, indicating resolution of shock or sepsis. Follow-up, amylase and lipase level showed normal level of lipase and significant decline in amylase level, which argued against pancreatitis. This supports the idea that the early enzyme elevation were likely due to stress from DKA, not through pancreatitis.
للي يحب يتعمق أكثر ويشوف شلون تصير الكيسات الواقعية بالمستشفيات بالعراق من أول لحظة المريض يدخل للطوارئ، شنو نسوي له فحوصات، شندزه تحاليل، شلون نربط الأعراض بالنتائج لحد ما نوصل للتشخيص الدقيق. فإحنا مختصرين هالنقاط كلها بكتاب واحد، 77 cases from real life for rotators. جمعنا لكم 77 حالة حقيقية واجهناها فعلا، وكتبنا كل حالة بأسلوب تعليمي ممتع. الصفحة الأولى سؤال، أعراض، تخطيط ومعلومات أولية بالضبط مثل ما ينعرض عليك بالمستشفى. الصفحة الثانية تشخيص، تحليل مفصل وخطوات العلاج الصحيحة. يعني كتاب يخليك تعيش جو المستشفى الحقيقي بس بطريقة مرتبة وسهلة وتفيدك بالدراسة والممارسة بنفس الوقت. إذا تريد تشوف شلون نشتغل بالإمرجنسي والردهات وتتعلم من كيسات صارت فعلا، هذا الكتاب راح يكون أقرب شيء للتجربة الحقيقية.
But despite metabolic improvement, the patient continued to have respiratory symptoms, and we noted patient started to develop unilateral crepitation. So we send the patient for chest X-ray. Chest X-ray in day 4 reveals an area of consolidation with air bronchogram. The next day, we sent to another chest X-ray, which revealed a bulging fissure sign, which indicate lobar expansion, together with a cavity lesion with irregular borders, suggesting active infection and possible abscess formation. In day 6, we see rapidly progressing consolidation over 24 to 48 hours, together with small area of pleural effusion and involvement of the left lung. This rapid progression is more typical of Klebsiella pneumonia than pneumococcal infection. Blood culture later confirmed the presence of Klebsiella species. These findings, radiological and microbiological, point toward the diagnosis of Friedlander pneumonia caused by Klebsiella pneumonia, a gram-negative encapsulated bacilli. Friedlander pneumonia, it's caused by Klebsiella pneumoniae, a gram-negative encapsulated organism. It usually occurs in alcoholic patient, diabetic patient, or chronically ill hospitalized patient with aspiration risk. It often involves the upper lobes, especially the posterior segment of the right upper lobe due to aspiration while supine. Radiographical hallmark is bulging fissure sign due to massive lobar consolidation, cavitary lesion from tissue destruction and abscess formation, rapid progression within hours to days, and it usually has high mortality rate despite treatment.